Okay, morning, everybody. Can you hear me? Dr. Sauvé, can you hear me?
I sure can.
Okay, perfect. Well, welcome. Thanks again. I saw you the other day, and it's good to have you back on here. So for you guys that are unfamiliar with this format, what we do is we'll allow you guys to type in questions in the chat, and we'll get to those if we can. Most of the time I'm able to. And for you guys on YouTube, you'll see probably the first 15 minutes of this. If you want to participate or see the thing in entirety today, head on over to Revero.health or meterx.com. You can sign up for free and be part of this community. Otherwise, it's come out as a podcast and will be up sometime in the next few weeks, I think. Okay, anyway, so do me a favor, and I know you've been here before, but just remind folks your background in case they don't remember who you were.
All right. So I'm Will Sauvé, and I'm a psychiatrist. I trained in the Navy, went to medical school at the Uniformed Services University in Bethesda, which I just happen to be near DC today, so right around here, and then trained in psychiatry. And then I think we talked about before, I graduated psych in 2004, which meant I went directly to combat without pass and go. So did all my deployments with the Marines. In Iraq exclusively. I never went to Afghanistan. And then I trained in brain stimulation when I was at my last duty station at the Naval Medical Center, San Diego. And then long story short, I've managed to kind of boil my practice down to like brain stimulation being all I do for about the last 7 years. And then we just recently took on the intranasal ketamine treatments here at our company, which is, actually we've expanded. I think since you and I talked before, we grew quite a bit. I think we're more than 150 centers around the country now. So my title is medical director, like in the Virginia region, but there's probably about 80 plus docs now working with our company around the country, and we're in well over 30 states.
Well, good to hear about the expansion. That's awesome. So I want to just ask you, obviously, you mentioned Afghanistan, and, obviously there's a lot of stuff going on now, and some of the veterans that serve there are, understandably, impacted by that in many ways. And, I spent time over there. I can certainly see where people are having problems with that. With regard to, there's a lot of PTSD. We know that veterans are at higher risk for suicide. I think something like I can't remember what the stats are, but it was something like 22 veterans every maybe month take their life or something, or every week. I can't remember what the number is.
They say 22 a day.
22 a day. Okay, so that's obviously that's 22 more than it needs to be for sure. What do you find, with this phenomenon? I mean, how can we impact that in a positive way? Obviously it's a combination of things going on, but what things can help our veterans out so that they're not dealing, or at least able to better deal with those types of things?
Oh man, that's a big conversation. You just rolled right into that, eh? I think that, I don't know, and I'd like to hear your opinion on this a little bit too. I mean, community support from the country, I think, is important. And this goes all the way back to, back in my psychiatric training, my mentor was a card-carrying psychoanalyst. He was one of the last ones left in the Navy. And, he always taught us from day one that like people kill themselves when they no longer think there's a reason not to. And that he firmly believed that personal connection, had one of the biggest effects of like keeping your feet firmly planted on this earth and feeling like you need to stay. And once someone was completely isolated, and he meant that spiritually and mentally, that when there were no more strings like keeping you on this earth, that's when people would finally act and take their lives. And that, I think when it comes to our brothers and sisters, I'm gonna guess without knowing the numbers, because no one's taken this statistic, that's still probably the biggest factor, is feeling like you're not part of all this, like however it is people are going to define community. And when you're not part of it and you're completely alone, and then it's like, why the heck would you suffer for one more day when, if you firmly don't believe that there's anyone who's going to care? The problem I have, the worry that I have about that, this is where I was curious for kind of your thoughts, Dr. Baker. When I came home the first time, like getting into like 2005, like that's when it was exquisitely popular in the United States for everybody to show their gratitude to veterans at all times, always. And like I go to the grocery store, start to open my wallet to pay for my groceries, and my military ID would kind of flash, and this 19-year-old woman behind the counter immediately stops what she's doing and says thank you, and like gives me this giant thank you. And that, not only did that not make me feel appreciated, it kind of made me angry, because it made me feel like, it took me a long time to figure this out in my mind. It made me feel like she had no idea. She was saying it the way you teach a dog to speak. And the poor thing just didn't have the first idea what she was thanking me for. And then it probably took me like a year of thinking to myself that, if I had expressed any anger towards that poor kid, it just would have hurt her feelings. And I had to like take a big step back and realize that even though I'm home from combat, it's my job still to like make Americans around me feel good. And I felt better about that. So the number one thing that I think the country could do to like maybe keep some of our brothers and sisters alive is do a better job of having everybody feel like they're a part of what we do here. But I don't exactly know how you do that, because just running up to people and saying thank you all the time is probably not that. In fact, if anything, it might be more isolating. I don't know, does that inject a little bit of despair into your morning?
Yeah, I mean, yeah, absolutely. I mean, that there's a lot of sense in that. And, we see that, one of the interesting things is there's different sort of, as you probably know, there's different suicidal demographics. And one is, older men tend to be, at high risk for suicide. A lot of people think these old guys died. A lot of them end up taking their lives. I think what happens is, either the wife leaves them or passes away, and their children are either not there or effectively not there. They don't have any relationship with their kids, and they're like, well, there's nothing keeping me here, and I'm just going to end it. Or they contract some kind of illness, and they don't want to, they don't want to spend their life suffering. And so I think you do have, when you're displaced from a community and you don't have a sense of purpose or productivity, then it's pretty easy to do it. I think a lot of the guys going in the military, and I think they feel like they're doing something, or they have a purpose, whether it's some people would argue how good that purpose is or not. But regardless, you've got people that were once felt like they had some value, and now they feel like they've been just kind of cast aside. And it's like we're seeing that with currently like some of the healthcare workers who were lauded as heroes during this pandemic, and now many of them are being threatened to be fired because they won't choose to do the particular medical intervention. And we're going to see the same thing probably in that group as well, I'm guessing. I don't, like I said, I think that certainly, when I was, I remember when I was deployed to Afghanistan, I was at the hospital, and I would take care of a lot of the, we do a lot of the trauma surgery. That was our main task, but we would still do the minor stuff. The guys who would sprain their ankles would come in, and, we'd take care of the troops. And, I'd be looking through their medical record, and I see a lot of them were on psychiatric meds, and they're walking around with loaded weapons everywhere. So it kind of got me like, wow, this is a little scary, because every single person, all 10,000 of us, were all walking around armed to the teeth. Even me, when I was operating, I had a 9mm strapped to my leg while I was in the operating room. So, it was kind of like everybody's armed, and a significant, many of them have psychiatric diagnoses, which is, it's a little bit disconcerting to think about that. And then we have, as you probably are aware, the level of depression, anxiety, bipolar disorder, PTSD, ADHD, on and on, is just going up and up and up in society. And I tend to think there's at least a dietary contribution, probably some of the, the way our socialization is occurring. Everybody's staring at screens all day, and you're just constantly being stimulated towards even hatred. If you scroll through a social media post, you're just going to find things that's going to get you riled up and upset. I don't know, do you find that we're getting worse off as a nation or as a society with regard to mental health?
No, I think it's worse. I I think it's worse, but it's also harder to measure. And this is something that I've noticed in the last year. So it's like I'm pleased to have something new to tell you, right? There's something new that I think I've observed since the last time we spoke. It's the American Psychiatric Association is publishing or promoting, other people publishing, and the APA is promoting paper after paper claiming that, like, since COVID started, depression and anxiety is now, like, we have so much more depression, we have so much more anxiety. When I go to read these papers, they're saying that there's more depression, and this is coming from the APA. So, like, one quite reasonably assumes they mean the illness of depression, right? Like, major depressive disorder is like twice as prevalent or something in certain parts of the country as it was before. You read the paper, it's literally people who responded to a survey saying they feel depressed. Like, there's no rigorous diagnosis being done. There's no diagnostic criteria. It's the same with anxiety. So it's, on the one hand, yeah, we're more depression, more anxiety. And I think that, COVID probably made people complain more. I don't know that it actually, like, made more people become depressed who weren't depressed already, but it probably made more people decompensate and raise their hands. And I think that anxiety disorders are, like, massively, massively on the rise. But at the same time, the whatever your opinion of as an orthopedist, the scientific rigor of psychiatry may have been, that is now a fraction of what it was. Like, because our number one, advocacy body is out there telling everybody that they're making it sound like anyone who says I feel depressed has depression and has an illness that requires treatment, and anyone who says they're anxious has an anxiety disorder. And that's, like, I see that going all the way back to the 60s, when you get like half the country addicted to Valium, because everyone who says they're anxious, like, well, you need a pill and then you move on with your life. When also, to validate what you said, I think the nutritional component is a huge part of it. And I'm sure you've seen this too. I mean, when I was in medical school, you didn't get type 2 diabetes if you were under 50. That just wasn't a thing. And I was in school in 1996. Like, it wasn't that long ago. And now, on a very regular basis, my patients, they come to me for depression, but they're, sub 30 years old. They have type 2 diabetes. I've had, 19-year-olds in the office with type 2 diabetes. The vast majority of people that I see have metabolic syndrome to one degree or another. And, like, I think it's been very well established now within the last couple of years, you can't grow a good brain without choline. And you don't get choline unless you're eating, like, a decent amount of meat and eggs. So that I even wonder how many of these anxiety and depression disorders we're seeing in people in their 20s come from just basically being malnourished their entire life.
Yeah, I certainly, like I said, orthopedics, obviously we have, I guess, some objective measurements, but I mean, at the same time, some of the objective measurements discount the subjective in some regard. It's like, I remember when I would do a surgery on somebody and the x-rays would look perfect. I mean, everything, all the components, the knee replacement components were perfect. Everything looked great. And the patient was still unsatisfied with the result. And you kind of just like, oh, well, there's nothing else I can do about that. I mean, I think in retrospect, had I addressed lifestyle disease, the inflammatory component of osteoarthritis through, perhaps diet and lifestyle, they would have had a better result, like I'm seeing now. But yeah, I mean, as you were seeing this, the normalization of the requirement for medication. I wouldn't even say, like I said, you've got this, we're normalizing obesity, we're kind of normalizing depression, we're normalizing psoriasis, we're normalizing everything. And it's just normalizing type 2 diabetes as if it's kind of meant to be. And oh, but don't worry, because we have the pill for you that's just right for you. And that is a bit of a problem, particularly if you're going to start to lower the threshold for the diagnosis. Just like, blood pressure. they just kind of dropped the systolic, upper reading from, I think, 140 to 130 now. And now that increases their capture by 30% more of the population or some number like that. That increases your market share by that much. And I just wonder if it's truly altruistic or if it's just trying to increase the bottom line. I'm very skeptical of some of these pharmaceutical companies, and I think for with good reason to be so. Tell me about, so I want to ask you, because you said your ketamine, intranasal ketamine and the brain stimulation. Let's go and talk a little bit about those things and how you're utilizing those. What's actually going on with that?
So what's new to us in the company is the intranasal S-ketamine. So I'll go after that first, just in case we end up being hard up for time. Yeah, and the only thing that's new about the intranasal ketamine is the fact that it's intranasal, right? So that ketamine, I think using ketamine in the treatment of depression has been gaining steam probably for more than a decade. They've been studying it at NIMH, but it had to be infusions, right? And the quick and dirty reason for everybody listening why ketamine had to be given as an infusion therapy is that maybe 95% of it gets killed in your liver if you put ketamine in your mouth, right? That's why there's no ketamine pills, because you can't get enough ketamine in your mouth to actually get it bioavailable enough in your brain to really do its thing. So, you have ketamine for depression. It looks super effective. The number needed to treat is kind of high, 8-ish or something. But the reason it's gaining steam is when it works within 2 to 3 infusions. You can see some people getting severe depression, not TV depression, but rigorously diagnosed, maybe almost going to be hospitalized depression, into remission inside of a week. In some of these cases when it works well, but it's not, something that's going to get FDA approved because it's a 50-year-old drug that's been generic for a good 4+ decades. And it's the infusion thing and it's expensive. So that's where in 2019, Janssen Pharmaceuticals brought S-ketamine, right? The S enantiomer of ketamine to the market. They were able to show that with that S enantiomer being more potent, being the active molecule, that it was bioavailable enough, through an intranasal spray that you could get away from having to have an IV infusion, and they could patent it. So they got it FDA approved in 2019. We took it on here, because we've been exclusively a TMS company as we've been growing out our centers and focused on that one procedure. But we always believed that we were a procedure/neuroscience mental health company as opposed to only transcranial magnetic stimulation. And even though S-ketamine is a chemical, it's still, I argued when we were discussing this that it was a procedure more than it is a drug, because it has to be it's a highly dissociative drug. You got to have 2 hours of observation. You take the nasal spray, you have to do it in a center. You don't take a S-ketamine nasal inhaler home with you and things like that. So we've now, FDA approved in 2019. We've been working on expanding it into our centers more and more, probably for getting on a year now, to offer this to people as an additional service on top of the transcranial magnetic stimulation therapy. And it's a procedure that you have done twice a week for 4 weeks. And if it's going to work, it will work within those 4 weeks. And if people's depression is improving, by the end of that 4 weeks, you can go down to once a week. And then if they're still doing better, you go down to once every 2 weeks. And that's on the label, that's considered the maintenance phase. So people would come in for, once every 2 weeks treatment, potentially indefinitely, as long as they're feeling better. And the final point about the S-ketamine that, I'm very attracted to about it is that it's the first, I would say, drug-based treatment for depression that is not really related to the whole serotonin, norepinephrine, and dopamine monoamine hypothesis of depression, which is, when it comes to antidepressant medications, that's all we've had for 50 years. And I'm so freaking tired of those 3 chemicals. If I never hear one of them again for the rest of my life, it'll be too soon. And S-ketamine finally gets you away from that. It has to do with the NMDA glutamate system and all sorts of interesting stuff about neuroplasticity and neurogenesis. And we might actually, we're treating depression by a novel pathway, but I think with S-ketamine, we might actually be treating depression by helping people's brains like literally get better, as opposed to just maybe flooding it with one or more of the three monoamines, which never seem to work in the long term.
Yeah, I can recall, my only real, a little bit exposure to ketamine when I worked, as an intern in medical or in residency, I was taking care of burned kids, and to do their dressing changes, we would, they would push ketamine on the kids. So they would go into this dissociative state where they didn't feel anything. It wasn't a respiratory depressant, which something, these other pain medications can severely depress the respiratory system, so you need respiratory support. So we would be able to change their burn dressings, which was pretty gruesome sort of thing to do. Almost, I think we had to do it about every other day, and then using it as as an acute pain medicine for. I think we also used it to. Some people would use it. Some of the ER docs would use it in the emergency room, like if I had to put somebody's shoulder back in place instead of. Hitting them with fentanyl and some of the stuff, they would do ketamine, and it was kind of an interesting thing. But I always remember their eyes would kind of roll back in their head, and you could tell they were in this sort of crazy state. But so the 2-hour observation time, because this kind of reminds me a little bit. I know there's people that are playing with things like hallucinogenic medications, plants and stuff like that for depression and other things. And there's also, and they do it in the presence of a licensed person, physician. I don't know, is there some sort of suggestive thing going on while you're there? Is there some kind of therapy that's going on while they're under ketamine, or is it just for observation so they don't have problems? Or what is the observation period there for?
So at baseline, the observation period is more than anything just to guard against someone having a bad time with it. So they can, people come in, they have their S-ketamine administration. Typically will have some like mild sedation and kind of mild dissociative symptoms. With the S-ketamine, I'm not seeing very many people that have a particularly remarkable dissociative episode with it, but they'll have it a little bit. And it almost without exception seems to resolve completely well within the 2-hour period. So the 2-hour observation, and then you're not supposed to drive a car after that, obviously. So it's like people are supposed to have a ride, come in and come out. And my number one, my smart alecky way of telling people about the observation is that nobody wants you crying in the back of an Uber. That's literally the number one reason for it. So people generally, the general practice is people come in, they sit in a chair, they have their administration, and someone is handy, not having to be in the room, and the standard of care has not been suggested that you're doing therapy during that time, but you're handy in case during that 2-hour period someone is having an uncomfortable time with it. And then we're there literally to hold hands. I think so far I've had one patient that cried for about a half hour, and every time afterwards she felt completely fine and said she wasn't really sure what that was about, but it happened like clockwork. It's like she'd cry for about 30 minutes. And then it would be over, and then she'd go home perfectly pleased with it. And I've had one patient that threw up. It's like some people get a little nauseated from it, but otherwise everyone is basically just being kind of observed for comfort's sake for 2 hours, and then they can have a ride home. That is in stark contrast to what the hallucinogens that are probably coming, right? Psilocybin's been given breakthrough status. Right, so the FDA is like literally daring anyone to give them the data that will allow them to just say yes to this, and this can become a psychiatric treatment. And that absolutely from day one, I would say psilocybin and MDMA. I saw someone mention that in the comments. That's been given breakthrough status as well. So MDMA, both of those are predicated on assisting therapy. So that, like, if you see psilocybin coming true, maybe within the next year or two, let's say maybe 2 years at the outside, that is definitely going to be like, if it's an FDA approved way, it's going to be a structured therapy program. and the psilocybin will be seen as something that's meant to add to that therapy. And I think it'll be the same with MDMA, which has also shown a lot of promise in PTSD, actually. I think maybe even it's getting more famous for that than it is for depression.
When you are, when you're dosing somebody with intranasal ketamine, is it weight-based dosing, or is it titration to an effect? And what level of consciousness are you looking to observe? Is there a certain, how do you know when you give them enough? Is it all purely weight-based, or how's that work?
It's been really frustrating. Our chief medical officer and I have been talking about that the past couple of weeks. It's ketamine for depression is kind of weight-based. It's the sweet spot's supposed to be about 5 mg per kg, or 5 milligrams per kilo. And that's pretty easy to figure out if you're giving infusions. But then the S-ketamine nasal inhaler, it only comes in 2 FDA approved doses. There's 56 milligrams and there's 84 milligrams. And it's one school of thought so far is that if someone tolerates 56, you should just go to 84. And I'm sure Janssen loves that idea, because you use an extra inhaler every session if you do that. So that's nice for them. There is also a suggestion that the milligrams per kilogram matter, so that, maybe for somebody who's no more than 110 pounds, maybe you never should go above 56 milligrams, whether they tolerate it or not. Interestingly, the level of impairment that people have from this S-ketamine administration doesn't seem to have anything to do with their ability to get better in terms of depression. So really, in terms of the level of impairment, sedation, and dissociation, that is all about someone's tolerance of the treatment. And basically, if you overdo it on day 1, they'll probably never come back, is your problem. But there was a big belief, I think, in the field that maybe people had to have a minimum level of impairment, or somehow they didn't get enough on board and they're not going to get a good antidepressant response. But so far, that's not been borne out. So they seem to be not connected at all.
Is the FDA approval is it for refractory or recalcitrant depression, or can this be a frontline therapy? Because I would imagine, like anything, if you catch somebody early, it's a lot easier to fix it than you've got somebody that's been 10 years of depression. They've tried 7 different drugs and they become recalcitrant to all treatments. So how does that work as far as, I would imagine the people that you're seeing are probably people that have had it for long-standing times and have tried other things. Is that fair to say?
It's kind of weird what they did, and this is probably related to just whatever data Janssen could give them. I wouldn't say it's completely the FDA's fault, but it's for treatment-resistant depression, and S-ketamine is labeled to be given in addition to an oral antidepressant. So it actually says on the label they're supposed to be given together, which, as a physician, I wouldn't necessarily stick to that. If somebody doesn't want to take a pill and they want to try S-ketamine, in my opinion, why not? But with that label of this being meant to be used in addition to an oral antidepressant, ironically, we're getting people that insurance will not cover S-ketamine for them unless they're currently taking a pill. And I've already had at least 2 patients who've tried 2 or 3 medications, didn't have success, actually got completely free of oral antidepressants, wanted to try S-ketamine, and their insurance said no, and they had to go back and start taking a pill that they didn't feel was going to do anything for them, so that they could get S-ketamine covered. So it's not only is it maybe not being looked at early enough, which I completely agree with that, but in some cases people are basically being arm twisted into taking a pill that may or may not be redundant, in addition to their S-ketamine treatment.
Yeah, I guess if you were a crafty patient, you get the prescription for the pill and not take it and just do the S-ketamine. I guess if it was working, I'm sure no one would ever suggest it. Yeah, exactly. Yeah. Let me ask you. So let's talk a little about the brain stimulation. The deep brain stimulation. I assume my brain is being stimulated right now, just by looking and talking, but maybe not. Some people would argue it's not. But tell us. Let's talk in a little more depth about the brain stimulation stuff you've been doing. I know we talked about it before, but let's talk about it a little bit again.
Wonderful, and that is my favorite. So what we're focused on here, in addition now to the S-ketamine, is transcranial magnetic stimulation. So we're still using this treatment modality where I can use a powerful electromagnetic field to induce current in the neurons. So with any of the TMS coils that I have available to me here at the clinic, I can electrify the neurons in your brain down to about an inch below your skull. And then, how exactly we do that is going to, have an impact on the therapeutic effect. For the treatment of depression, which was FDA approved in 2008, like TMS in its modern form has been a thing since about 1985, going back into the research arena. But as a therapeutic thing, that was 2008. We're stimulating neurons specifically in the left dorsolateral prefrontal cortex at 10 hertz or 18 hertz now, kind of depending on the coil you use. And at those frequencies, we're going to excite those neurons. So after a few thousand pulses at 10 hertz or 18 hertz, that section of the brain that I was stimulating is going to be at an increased level of activity and probably going to stay that way for an hour or three. And the antidepressant effect is generally attributed to that. And the hypothesis is that by increasing the activity in the left dorsolateral prefrontal cortex specifically, so right in that one spot that I'm pointing at, it seems to be improving cognitive control and getting control of some of the other areas of the brain, like the default network, which might be responsible for negative ruminations, and getting control of some of the limbic areas, and increasing even the connectivity in that whole circuit, the frontoparietal network, so that whole picture might be leading to improvement in depression. And then we do it 5 days a week to the tune of about 30 sessions, which is also meant basically to train it to stay that way. So we're taking advantage of neuroplasticity and neurogenesis, and you do see that borne out. We see, I think we've treated more than 15,000 people now, our company and company-wide, ever since our company started doing our thing about 8 years ago. And out of all comers, we're seeing not quite 70% getting at least a 50% improvement in their symptoms of depression, about almost 40% getting completely into remission. And then the published data of follow-ups shows about 2/3 of people still doing fine after a year with no further intervention. And some of those people are even medication free. So that's the basic thing. That's still the complete centerpiece of what I do. Since we last spoke, actually this might have happened already when we talked, but now I've done a lot more cases. The TMS was also FDA approved to treat obsessive compulsive disorder. And that's a different coil. It actually stimulates the entire middle part of the prefrontal cortex. So the left and right medial prefrontal cortex, all the way down to the anterior cingulate cortex. So this OCD coil can reach actually closer to 2 inches below the skull. And the interesting thing is when we're treating OCD, we have to do a dumbed down version of exposure therapy for OCD. So my patients with OCD, they come in and I've had to teach our staff to be cruel and purposely poke at them to get their symptoms really provoked. And then we start the stimulation 5 days a week. And what you'll see is their OCD symptoms like being driven into extinction a lot faster than they would by just doing exposure therapy alone.
Yeah, interesting stuff. Do we know, I mean, I'm sure there's been, data looking at the brain through either fMRI or PET scans or whatever. What's going on during and after the stimulations? You talk about neuroplasticity, but do we know physically or physiologically what's actually happening?
Only in the vaguest terms. So I think everyone in the field is still, of course, like dying for that information. So that's not known. It's not known well enough yet that you would do before and after scans on an individual patient, because that would be like $5,000 you'll never get back, and it doesn't prove squat. but in the, like, there was some paper maybe getting on 4 or 5 years ago now that was a functional connectivity scan. Have you seen those things? Like fMRI? So they show you they don't just show you the pretty picture of the different part of the brain, you know, orange and another part blue. They actually show you the networks working together. So you can actually see when one part of the brain's activity goes up, what other part goes down in response. And you can kind of see the symphony happening. That study indicated that in depression, you actually did see that left prefrontal cortex not only having reduced activity, but having less connectivity. So it's not carrying its weight like a weak muscle, and it's not really plugged in. And then I think there is a little bit of work out there, but again, none that you can translate into clinical practice, showing that in patients that respond, you increase the activity, but you also increase the connectivity. So that you really did, you know, if I treated somebody with typical TMS for 30 sessions, I will have lit up that whole frontoparietal network circuit about 90,000 times, you know, by the end of the 6-week time frame. And there is evidence that, you know, you've really made that circuit, you know, much more strong, and it's much more connected and plugged in. What is coming, and this paper actually might get published within the next year. There was the company that made the OCD coil, they're called Brainsway. So think like brains, plural, W-A-Y, Brainsway. They got an early signal that that coil for OCD also seemed to have a lot of good effectiveness for depression. So they did a big multi-center trial. We participated in it, where we compared the original TMS coil that Brainsway makes for depression that stimulates the left prefrontal cortex with the OCD coil that stimulates here in the middle, all for depression. It was really cool because there was no fake treatment. So people came to participate in the study. They got 4 weeks of free treatment for depression. And I got to tell every one of them, you're getting real treatment one way or another. You're just getting the experimental condition or the approved condition. But the cool thing that they did, they gave us a quantitative EEG machine that was shielded against the coil. I don't know how you do this, but we had a 20 lead EEG that would actually get a clean signal with 1.5 Tesla magnet pounding on it. And that, like, I'm good at physics, but I'm not that good. So I don't really know how they achieved that. But the reason for getting that quantitative EEG during the stimulation is that they're looking for a signal that will be able to show what the difference is pre, during, and post-treatment in like people that responded to one coil or the other or didn't respond at all. So like, ask me again in a year. You know, we finished the trial. The data hasn't even been unblinded yet, so we don't know, you know, who was who or who got what treatment. But everyone that we saw did so well. We're pretty sure both coils worked, and we're of course really excited to see this like during treatment live action quantitative EEG to actually see how brains are responding to the stimulation in real time.
You know, and obviously depression has a number of different etiologic factors. Is there a way to predict, you know, like, you know, let's say someone is dealing with a, you know, sort of the association with chronic disease, or somebody has a traumatic event and they're having depression. Is there a way to predict who's going to likely benefit based on what you think might be the contributing factors to their disease?
Not yet. So that, like, there's a bunch of stuff out there that might help you guess a little bit better, but nobody's got like a good prediction. So you can do like some examples. You can do genetic testing, like some of the brand names are like Genomind and GeneSight. And mostly what they do is tell you how well or not well most of the psychotropic drugs are metabolized in your liver, you know, through the P450 system. But they do include maybe 6 to 8 markers that might tell you a little something about depression. So like one was the serotonin transporter gene. And if you have a mutation on that gene, there's a pretty good chance that you probably won't respond to any of the serotonin reuptake inhibitor class. And if someone got that test on you before you ever started treatment for depression, it might give you a reason to skip like three of your first drug trials and just move into something that gets away from the serotonin class. To get back to nutrition a little bit, most of those tests will also tell you whether or not someone has the MTHFR mutation, right? That, it sounds like an acronym for a very, very bad word, but it has to do with like methyl something transferase, like reductase at the end. And that's all about, do you turn folic acid into L-methylfolate? And if you don't really make L-methylfolate very efficiently, then you don't make serotonin very efficiently. And the whole idea there, like years ago when L-methylfolate was FDA approved as an augment to antidepressant drugs, the idea was that if you didn't make L-methylfolate, then if you take a serotonin reuptake inhibitor, you're inhibiting the reuptake of nothing because you don't really make serotonin. And that's all well and good. But again, the FDA approved it as something to add on to an antidepressant drug. And I argued 10 years ago, if you have that mutation, you were born with it, why wouldn't you just give someone L-methylfolate and fix the metabolic hole before you tried to give them drugs on top of it? And I think that's and then not long ago, kind of as part of the whole carnivore journey, I learned that if you have the L-methylfolate mutation, and one of the other consequences of that is you build up large amounts of homocysteine. It's like 3 milligrams of riboflavin a day will completely solve that. Like the homocysteine will just go back to normal. So then, the question I have for all of us, right? We don't have this research yet, is does that mean that with riboflavin or the right dietary source of that, could you solve your L-methylfolate problem? And are you going to start making your monoamines more efficiently? And is that going to help a certain number of people out of depression and anxiety without ever having to take pills? And they may or may not even need to take like pharmaceutical grade L-methylfolate, which nowadays is a lot less expensive, but it's still not nothing. Then we don't really have time today, but don't even get me started on the whole inflammation thing, because all the cool kids in psychiatry are talking about inflammation now. And I think that might actually be one of the biggest drivers of probably more anxiety than depression, but huge driver of anxiety and depression in this country, like as a rule. And I worry that like if we fixed inflammation in everyone, I don't think everyone's depression would be cured. But I think that if inflammation's not fixed, I think most of what I can do to treat people isn't going to work.
Yeah, I wanted to, because obviously within this community, a lot of folks have seen tremendous gains with regard to mental health, whether it's anxiety, depression, or some other form of mental health disorder, with just a dietary change. And some may still continue with other mechanisms. Within your practice, are you including lifestyle as well as some of the deep brain stimulation, ketamine treatment? Have you tried that, or is it something you can do?
I try so hard. It's one of the nice things about our practice is that I'm a 1099 independent physician. I practice as I see fit. So no one in our company is suggesting that there's areas of practice that I may or may not do, but I'm finding as a rule, most of my patients are so resistant to, they don't want to hear about it. And then of a fairly small number that want to hear about it, they think it's all very interesting. And then, getting somebody to make a change. And then every once in a while, and I mean once in a while, we have a great day because someone hears it and they make that change. And that, interestingly, and when it, doctor to doctor, how that all works, I think the rare cases where I get through to somebody and they make a change, the only reason that they listen to me about nutrition is because, thank heavens, when I'm sitting across, I look to them like I know how to eat and I know how to train. So it's like, at least I project the image that it's like, yeah, I haven't eaten plant matter in 3 years. And a patient will look at me and say, well, you look pretty good. Maybe I can try that. I'm like, if that's what it takes to convince you, I'm really glad I did it. Yeah.
Yeah, I mean, there's certainly something to be said for, walking the walk and being able to demonstrate, that you can actually have control over your own health and body when you're trying to inspire. It's always like going to the dentist whose teeth are all falling out of his head, or the barber who's got a horrible haircut, or, whatever. I mean, as much as people say you don't have to be a player to be a good coach, there's still some value in being able to demonstrate health as a physician. One of the things, and I don't know if you share this frustration, but I mean, we're in the middle of this pandemic, and even 18 months into it, there is literally almost no discussion around metabolic health, obesity, not even can we do anything about it, but should we do anything about it? I mean, you can ignore the argument, what's the best way to treat it? I mean, it's not even being discussed. It's as if it's conceded that there's nothing we can do to improve people's health, and therefore our only options are to find a pharmaceutical solution or some sort of, other, questionably good way to treat it. I don't know if you share that frustration or not.
I share that frustration. If I were prone to anxiety, it would make me really upset. It's like, but fortunately, I got most of that erased from my body. The Navy started it and the Marines finished it. So I don't have those unpleasant feelings anymore. But did you see I don't think it was fake. Did you see the thing that came out of Delaware Public Health? That they made some tweet where they put out that, do you know that you have to run 5 miles a day for a week just to lose a pound of fat? You're much better off taking a vaccine. That
I did not see that. No, I didn't see that.
This is the first.
I didn't see that, but that's unfortunate. I mean, it's like
it's nuts. I mean, it's bad enough that someone who's not a doctor would say such a thing, but to have that, this is public health literally saying, I don't think I've ever heard this before, ever, in my entire career, that someone from public health said that exercising is too hard. So don't think of that as a viable strategy. That I wouldn't have been thrilled if they had said you need the vaccine and exercise. Even then I would have been less than pleased. But to hear them literally say no, this is way too hard, it's not worth your time, just come get the shot. I thought, I really did think we've sort of hit a milestone, actually, when it comes to what public health advice is turning into in this country.
Yeah, you got to wonder about that. That is, and the fact that, early on in the pandemic, there was this was early on, this was, last March or April when it first came out, and there was some dietitians that penned an editorial in one of the national magazines, online national magazines, saying that now is not the time to go on a healthy diet. You're going to be at home, it's going to be stressful, just continue to eat the food that you enjoy, just don't worry about dieting. And everyone took that to heart, and as we saw, I think something like 29 pounds was the average amount of weight gain for an American, which clearly has put them on the path. It's because it becomes a very slippery slope. If you get into that habit of eating garbage and not exercising, and then you have that, you've got this increase in inflammatory cytokines from all the excess body fat, which then makes it painful to exercise. And then, not to mention, you kind of alluded to some of the mental health issues that occur to that. So we've just created, it's kind of ramped up the chronic disease like crazy with this. And now they're telling you don't bother to exercise, just get a shot. That is insane. Let me just, we've got a few minutes here, just touch on inflammation in the brain, if you don't mind, just in the next, if you can do it in 5 minutes or so. I don't know if you can, but why do we care about inflammation and brain health?
It's just for a couple little things, in 5 minutes. Inflammation drives a couple of metabolic processes in a way that you don't want. So that's item number one. If I know I said I never want to hear the word serotonin again, but we'll make an exception just now. That the way serotonin is metabolized in your brain, the way it's created and the way it's destroyed, if you have a brain full of cytokines that's one of those chemical reactions that it'll go left instead of right. And the serotonin production goes down this pathway called the kynurenine pathway. And that pathway is directly neurotoxic. So it's like if you have chronic inflammation, right, and the whole key there, and you know what, not to flatter, but I think I learned this from listening to you. The key there is the delta, right? It's like the body needs to be inflamed, but what the body needs to do is the body needs to go from no inflammation to a lot of inflammation, and then very quickly go back down to very little inflammation. It's like that's how inflammation is supposed to work with an acute injury. But say, for instance, when you put on your 29 COVID pounds, and we have, maybe 30, 40, 50 pounds worth of, excess adipose tissue that's putting out adipokines, and you're in a chronically inflamed state. So it's always this constant moderate level of inflammation. That's when you're going to see the neuroinflammation, right? Because that any inflammation is by definition neuroinflammation. All those cytokines get into your brain. And even just that one process, it's suddenly driving your serotonin metabolism in a direction that is just killing neurons, like literally right then and there. Another way to think about it that's equally horrifying is the post-concussive syndrome. So when you bump your head, if you bump your head hard enough to get your bell rung, right? It's like, that's what we would call it where I came from. That was the language my Marines would always understand, right? I'm like, have you had a concussion? They're like, no. And then it's like, did you get your bell rung? Well, yeah, so it's like, okay, you had a concussion. And if you get even a tiny concussion, and most people will recover from that. And frankly, I think most people will recover quite well from pretty significant concussions, right? If every professional fighter got dementia, that would be a dramatically larger crisis than we know it to be. So it's like more people are okay than not. But if you get a concussion and then 2 or 3 weeks later, you're diagnosed with the post-concussive syndrome, which is, the cognitive impairment, the headaches, maybe the dizziness and everything that goes with that. That was not from the concussion. That was from an out of control cascade of inflammation that goes on for 3 weeks and causes, neuronal cell death for the entire 3-week period. So that's another one where it's like, well, if you didn't have chronic inflammation to begin with, would you have an out of control inflammatory cascade that caused this like massive post-concussive syndrome, and then frankly a mild TBI? And what do you know, 50% of that population gets diagnosed with depression in like less than a year, right? So that's hugely related to that. So inflammation might even be, I'm really starting to wonder if inflammation is setting people up for having significant head injuries from the normal rough and tumble stuff that we all lived with when we were kids, right? Like fell off our bikes all the time. Nobody got post-concussive syndrome. And I can't help but wonder if it's because we weren't little walking balls of inflammation all the time. And then like, never mind the fact that if you're constantly inflamed, your immune system just can't function. It's like, because it's too busy fighting everything all the time. It's like, how are you supposed to, mount an immune response to like anything else that comes in your body? And then I think it's becoming more and more clear that it's a setup to have an autoimmune process down the road. So it's like your poor immune system's just getting, that bell is being rung all the time. And eventually it starts getting some cross signals and starts turning on you. And you start eating up, heaven knows what in your body. And then we could again be talking depression, anxiety, multiple sclerosis, mild TBIs, who knows what. What was that, 4 minutes? That's the 4-minute version of like why I'm so upset about chronic inflammation.
Great job. I've got one more. I don't know if you'll know what this is, but Becky was asking me if you can talk. There's an acronym called BLAST, B-L-A-S-T.
I don't know what that is.
I don't either, so I'm sorry, Becky. None of us know what it is, so we can't comment on it. Okay, where can people find out about if they're interested in what you do, they want to learn more, they want to perhaps even, become a patient? How do they get that information?
I'm gonna type it in. Our company is Greenbrook, and it's greenbrooktms.com. Suddenly I forgot how to type. So there you go. greenbrooktms.com. You go on that website. That's the national website. You know, anywhere in Virginia between Richmond and DC, if they're looking for me specifically, you'll find locate our centers and so on, and eventually you'll find me and all that. But people will also find like where we are as a company. And part of our vision right from the beginning was to make it easy. We figured people with depression have a hard enough time picking up the phone as it is. So, you know, you go on the website, call this number, we handle the rest. You know, we make it very, very simple to come and see about TMS treatment and now to see about S-ketamine treatment. So have that website, people should be good to go. And
All right. So
I can answer Becky's
Greenbrook,
question about Blast because she's got me on Instagram. So Becky will find me there and she can
okay.
continue this and I'll find out what Blast is. Answer
All
that.
right. Well, William, thank you once again for your generosity of spending the time here. Maybe we'll get you back. You said in a year or something new, so you'll have some more data. So maybe we can share that again. Keep up the good work and appreciate what you do.
Hey,
And
very welcome. Thanks
everybody
so
else.
much for having me. I was going to get on last week, but we had to have a big conference call because this may shock you, but we've started using a new electronic medical record and it's not going well. So
No kidding.
had a big old crisis, but I'm going to jump on as many Mondays as I can. So you'll see
Love to
my
have you. Love to have you.
face soon.
Yeah, we love to have the input of other healthcare providers. Thanks a bunch, William. Take care. Guys, I got to go. I got to do another podcast right now. You guys have a great day. We'll see you tomorrow. Bye-bye now.
Thanks.